How's it going, everyone? Today we're going to be talking about the basic treatment of an upper GI bleed. So this is assuming you've already made that diagnosis. The first thing we're going to want to think about is airway. It will become abundantly clear to you whether or not a patient is protecting their airway based on whether or not they're able to converse with you. Maybe they're throwing up a massive amount of blood and are at great risk for aspiration. The thing that makes this tricky in an upper GI bleed is that patients are often very hemodynamically unstable. So you want to resuscitate them with as much fluid, maybe some blood, massive transfusion protocol, prior to giving those peri-intubation medications that are going to drop their blood pressure. And of course, if they're protecting their airway, you're going to want to make them NPO because they're eventually probably going to need an endoscopy. Second is you want to get access in them. This will often be done for you already, but you want to get 2 large bore IVs, 16 gauge, especially if they're hemodynamically unstable. 18 gauges are okay, but especially if their blood pressure is low, you want a 16 gauge or lower. You can also think about a cordis catheter in terms of a central line as well. In terms of blood, you definitely want to consent them and get a type and screen and crossmatch as soon as you can if someone is bleeding, of course, and you want to give them even uncross-matched blood if they're massively unstable. If they're not unstable and you don't feel like you need to immediately transfuse them with uncross-matched blood, generally we shoot for a hemoglobin of less than 7. That is, of course, entirely dependent on your clinical judgment and the clinical situation. Remember that when you're massively bleeding, your hemoglobin may not actually be reflective of your true hemoglobin because it takes a little bit of time for that hemoglobin value to re-equilibrate with how much blood has been actually lost. Next, we're going to think a little bit about any coagulopathy. So if a patient is on a blood thinner, say Eliquis, warfarin, we're going to want to think about potentially reversing them depending on their clinical situation. Now, a huge caveat with this is that patients with cirrhosis are going to have a high INR, and you're going to want to think, oh, they have a high INR, they're at greater risk of bleeding. Maybe let's think about giving them some prothrombin complex concentrate or what have you. Actually, the INR is not taking into account the fact that both procoagulants and anticoagulants are not being made by the liver, so that INR doesn't really tell you the whole picture in cirrhosis. Oftentimes, these patients with cirrhosis are actually hypercoagulable, and reversing them can be potentially dangerous. Next, we're going to want to think about circulation. So we want to maintain our mean arterial pressure above 65 ideally. We're going to do this primarily with fluids and blood if we're giving it, but we may need to resort to using pressors as an adjunctive treatment as well. Typically, norepinephrine, brand name Levophed, is going to be what we're thinking about in this type of clinical situation. Next, we're going to want to have a PPI, proton pump inhibitor. Typically, this is pantoprazole or another PPI, 80 milligrams IV one time, followed by 40 milligrams twice a day. Drips are not necessarily evidence-based, and there's conflicting information out there, but from what I have seen and read in the literature, a protonic drip is not necessarily something that is better than twice-a-day dosing of a high-dose PPI. One thing I want to mention is why we do administer a proton pump inhibitor in the first place, and that is all due to the pH. If that pH is elevated, that makes the clotting cascade work a lot better. That clotting cascade is going to work so much better if that pH is higher and not the acidic low pH of the stomach. Next, if this patient has cirrhosis, there are some extra things we want to think about. One is giving ceftriaxone. This is actually one of the only things that confers a mortality benefit to patients who are having variceal bleeding secondary to the cirrhotic liver disease. We're going to give 1 gram IV for infection prophylaxis. And the theory behind this is that patients with cirrhosis have a greater gut bacterial translocation when they have episodes of acute GI bleeding, and that's going to predispose them to different types of infection. Second is we're going to want to administer octreotide, which is a somatostatin analog, a 50 microgram bolus followed by a 72-hour drip. That's going to cause splanchnic vasoconstriction and help reduce blood flow to any variceal bleeding. Now, all this to be said, just because someone has cirrhosis does not necessarily mean the bleeding is variceal, but you're not going to know that until you scope them. So you want to do these things while you're calling GI and getting them to more definitive treatment. Which brings me to my next point. Of course, we want to call GI. If someone is massively hemorrhaging, you're going to want to mention the words, "This patient is in hemorrhagic shock," to get them to come evaluate this patient quickly. Shock is not something that can wait until the next morning. And then if endoscopy isn't working, or let's say you're working at a critical access hospital, you don't have access to a gastroenterologist quickly, some temporizing measures you could potentially think about include a Sangsticken Blakemore tube or a Minnesota tube. These are capable of direct mechanical compression causing hemostasis. And you can also think about backup interventional procedures such as placement of a TIPS, esophageal transection, gastroesophageal junction devascularization. But that's the basic algorithm. Please feel free to leave your opinion on it, any updates, recommendations, changes, disagreements down in the comments below. Please like and subscribe, it really helps out the channel a lot.